This patient had a ruptured MCA bifurcation aneurysm on the left, which was operated on earlier. In addition, there is also an unruptured MCA bifurcation aneurysm on the right, which is shown in this video. This right bifurcation aneurysm looks mainly like a downward projecting type, but there is also a small portion of the cranial portion of the aneurysm dome which is more intertruncal type. The aneurysm dome will be partially attached to the temporal lobe, so that excessive retraction of the temporal lobe needs to be avoided during initial dissection. After performing right lateral supraorbital approach, the arachnoid over the sylvian fissure is opened on the frontal side of the sylvian vein. Water dissection is used to expand the dissection plane. The sylvian vein is large and obstructs the view into the sylvian fissure, especially the temporal part. Since the aneurysm is going to be against the temporal lobe, we mobilize the sylvian vein and with arachnoidal opening on the temporal lobe side. A large M2 branch is identified and followed proximally towards the bifurcation. At the bifurcation we can see the frontal M2 and on its lateral side is the aneurysm dome, which has been to be mobilized. Part of the dome is pointing towards the temporal lobe as expected from the perioperative images, but smaller portion of the dome is located between the two M2 branches as in intertruncal type bifurcation aneurysms. M1 is identified medial to the aneurysm and temporary clip is applied on the M1 trunk. Now we can see also the other M2 on the opposite side of the aneurysm. Pilot clip is placed over the aneurysm dome and both M2s are checked. After removing the temporary clip, the aneurysm dome is coagulated safely under the projection of the permanent clip. There is also a tiny aneurysm bleb on the opposite side of the superior M2. Under the protection of temporary clip, the bleb is coagulated down and cottonoid with fibrin glue is placed on top of it to induce scarring. Papaverine is applied. As seen, the opening of the sylvian fissure does not have to be extensive. In this case, only about 1 centimeter was enough to have a good control of the situation. On postoperative CTA, the M1 and both M2s are patient.